I don't want her either.
So
Do I have to put a no-go backs?
Number 15 is just, I think you can get rid of because it already falls underneath the number
Endocrine,
4
yeah.
of significant history of endocrine disorders. It
Yeah.
already falls under that.
Yeah.
Oh, you mean number 17?
No, it's not
No, it's
insulin
15.
dependent.
I thought-
Yeah, well, 17.
Did we go from
We're still using the old number.
Oh, I'm sorry, excuse me.
Yeah,
Wrong list.
sorry about that.
So insulin-dependent diabetes mellitus.
Well, but
I think it's fine to have that.
endocrine.
so yes, it does fall under the significant endocrine disease or whatever, but if we're not going to list insulin dependent, then how are we excluding non-insulin?
Yeah, you-
That's the purpose of that right there, right?
Yeah, you have to differentiate between diet control and insulin dependent.
Right.
And
That's
also-
one place to do it, yeah.
I mean, then you should probably change it to medication because if somebody's on metformin or glyburide, is that the same as insulin or is it different from insulin?
So medication dependent.
But what if you're taking metformin for PCOS or?
Well, no, so you do medication dependent.
Yeah, medication.
Yeah, rather than insulin dependent.
Should that be like a second or part of the sentence for the one about endocrine disease? Like, would that be more?
So is there some consensus that it should remain its own separate and it's going to be medication-dependent diabetes mellitus?
No objection to that. It's just
Okay. 18, serious congenital abnormalities affecting childbirth.
That maternal is what we're talking about.
Yes.
Well, it has to be because it's a history section.
Just put the term in there for some question.
And serious maternal congenital abnormalities affecting childbirth, if you want to make it clear.
Say that again, Carrie?
You could put maternal in there, serious maternal congenital abnormalities affecting childbirth.
Can you give me an example of what they're talking about? Severe scoliosis thing? Like what?
Pelvic deformity, some
How about spina bifida?
osteogenesis effect.
Spina bifida could be a problem. Subclavian tumors. Yeah, that would be.
The subcutaneous uterus would fall under
But that's
the uterine abnormalities, number 1.
Yeah, that's you.
There's almost nothing that wouldn't
Well,
also be
spina bifida would fall there, it's not, it's not, I think it's anything else.
Is there a neurologic disease? Is that?
yeah.
That would be a neurologic. I don't know, I'm just wondering what one would be.
That's all I can think of.
It's just that it's an unusual thing to have a mother.
Those people aren't really gonna, like, come to us anyway. It's kind of there just as it needs to be.
The gesture.
Does it need to be there?
I'm fine with it.
Like, is there a reason to remove it?
I don't see any reason.
I mean, because it's uncommon, doesn't mean it still happens.
Yeah, it's just an additional clarifier, kind of like leaving the diabetes thing. Fine.
Yeah, but I can't imagine that even if it wasn't in there, that if a woman came to you with spina bifida,
Well, exactly, but, there's a lot of these, a lot of things like that on the list.
Right.
We would just automatically refer for anyway, so.
paraplegia.
All right.
It looks good there.
Okay, we'll move on. 19 is family history of serious genetic disorders or hereditary diseases.
How does it serve the woman to be given a referral for that in the absence of any confirmed problem with the current pregnancy?
And in the population we serve, there's a number of people who would not go in. They don't care. They will accept whatever baby God gives them, and that's what they want. They don't want a referral. They don't want to be counseled about the likelihood of abortion, being the best option for them. They don't want to hear this message. They know they're going to get it, and they've been in pregnancy situations with physicians where they have been pressured. There are doctor's offices that will not see people, for example, who don't want prenatal screening. They say, find another physician, that's your choice. I know the patient education booklet says, you know, that's their choice, but that's not really their choice. And sometimes you say, well, there are lots of physicians out there, but maybe they're on Medi-Cal. Maybe they're on a restricted list of physicians they can see under their particular insurance. So it's very restrictive to consumers to have that on there.
Actually, this was in the previous regulations that I believe was taken from the California Association of Midwifery Standards of Care.
It didn't have to go on there for a good reason.
The original, the one that was adopted in 2005, came from a collection of lists from all over the world, all over the English-speaking world, and if you read enough of those lists, you'll find things like that that maybe for our population are not so helpful. But there wasn't any very specific reason other than it was on the majority of the other lists, and so I included in that.
I certainly see the same patients who don't want to have anything done, don't want to have any testing, and respect their autonomy in making that decision. So the issue of genetic disorders, I don't know if anybody in this room can keep track of what's happening these days in the changing field, and it's almost impossible for any one provider to keep track of what is now available that wasn't available last year or 6 months ago. And I think, to me, this is a way of trying to maximize the likelihood that patients fully understand what kind of testing is currently available today that wasn't in their last pregnancy or even 6 months or a year ago. And this field is changing so much, it's impossible for anybody to keep track other than a geneticist.
I agree with you, but I don't think it should be required. The midwives can give the client, the woman, the option. She can decide to see the geneticist or the perinatologist or not, but to require it, I think, takes away her right to choose what she wants, to choose whether she wants to be tested.
I mean, nobody's forcing her to be tested. We just want to make sure there's fully informed consent, and I can't keep track of what's going on now in the genetic world compared to 5 years ago. And so, you're not requiring them to be tested. All that you're trying to do is make sure that they're informed to the best amount about what options are available currently.
I agree with the changes, but I misstated. It's not a matter of them being forced. It's a matter of requiring them to see someone. Many women do not want to be tested, period.
I think part of
They
our,
should have that option.
I think part of our informed,
They don't want to talk about it.
part of our informed consent includes, I may not be completely current on all of this, and I could refer you to a maternal fetal medicine specialist or geneticist if you desire more information than I can give you. But the woman should get to make that determination. This is not likely to impact her pregnancy necessarily.
I have a hand over here. Just identify yourself. Yeah. My name is Michelle Welborn. I'm a licensed midwife. And I think that the point that you're making that, no one who is not a genetic counselor can keep up with this is exactly the reason it shouldn't be on this list. Because we should be referring to a genetic counselor, not to an OB, who also can't keep up on it. There's no reason to send them to an OB in this situation. I also feel that this puts this particular bullet point here puts an unfair obligation on the midwife and the client in a number of other cases. So what about the case where you've got a woman who is a known carrier of cystic fibrosis, which we could say is significant, right? And yet the partner isn't. So once she knows that and she's been seen by a genetic counselor, the way this would read right now would suggest that with each subsequent pregnancy, she still needs to go see an OB, who's not the right person for her to see in this situation. And if she knows her carrier status and the father of the baby's carrier status, even though she has a significant history, it has no relevancy to that pregnancy. And that should be easily talked through in an interview.
Kelly Olson, licensed midwife. Another aspect of that is that this is something that it's not something that the practitioner is assessing on the woman. You're not noting her blood pressure or anything like that. This is something that the woman is self-reporting on a history form or in your discussions as you go through her history. So she has some level of awareness that there is this history of that. And so you have, it automatically triggers a conversation that you have as part of your informed consent and part of your history taking, that she has these options and that you would, it might be something that would be well worth her talking to a genetic counselor or whatever. But it's something she's self-reporting. It's not like you see that or you observe it or you can feel it with your fingers or whatever, like many things that we have. She's reporting that to you that will just automatically start the discussion.
I think most of us get the signed informed consent in the AFP booklets and, talk about, there are several, there's nuchal translucency and specifically the windows of when to do those. And it's not my bias, it's just giving them information, making sure that they have true informed consent, collecting the signature page, asking them if they have any questions, and disclosing. That is not our area, my area as a midwife of expertise. And I'm happy to refer you to a genetic counselor, a perinatologist to do that if they choose.
So I want to just bring us back to the statute as to whether a family history of serious genetic disorders or hereditary diseases is likely to impact the current pregnancy. From our discussions, I'm not reaching a good conclusion on
I think there are
that
some
issue.
that would fall into that category of yes, and a whole lot that would be a no. Without listing each one individually, you're not going to get where you want to be.
Would it help to change family history to personal history? Would that make it? I'm not sure that would help with the objections, but it certainly would make a difference in terms of likelihood and relevance.
It makes sense to me.
What is personal history?
Just that person.
Just only that one person.
Haven't we sort of covered that with many of these other things?
And that
of family genetic disorders
That's what we're
show up with their cardiovascular, renal, hepatic, neurological, endocrine, pelvic, all these. I can see your point in personal is.
We could just strike, I don't even think any personal, just history, because it's all referring to the maternal.
Right.
So we strike family.
Does that leave the dad out?
No, I don't see how it's useful
Oh,
for anybody.
It seems
So
like
it serves no
any
purpose if the
disease,
dad isn't in
any
it.
serious genetic disorder or hereditary disease is going to be one of these that we've already listed. So it seems like
Perhaps
there's no purpose to it.
it's too overbroad, and
It's very broad.
if there are serious genetic disorders or hereditary diseases where you're like, this has got to be on here, or they'll never get through the rulemaking process, then we might have to put some more individual conditions on there. But this as a separate category, it sounds like it's just too overbroad and encompassing.
Yeah.
So my proposal is we strike it as it's worded.
Yeah. Yes.
20, prior fetal structural or chromosomal abnormality.
I think this is the same argument, and if we end up with a fetal structural or chromosomal abnormality, we're going to be referring, but just because they had one in the past, then we do the consent for additional testing, and it's up to the woman to decide what additional testing she wants to have based on whatever previous problem a previous infant had. And some women are going to say, I'm not going to have any. And that should be her right to determine that. It's, you know, we could include polydactyly in that. Okay, so you got 6 toes instead of 5, and I'm going to have to refer for that?
So in our phone conversations, we came up with adding affecting mode of delivery, because that would get rid of that problem right there, and would actually require relevance in decision making.
Well, how would a prior problem affect the current mode of delivery?
Well, I guess that comes to what's the likelihood of recurrence, which I don't, certainly not 50%.
Affecting mode of delivery, there's only a few things that you can think of there that can happen. Spina bifida maybe, and hydrocephaly, but how likely are those to recur? Without us noticing something during the pregnancy and having it covered under significant disease arising from the pregnancy. Yeah.
Or offering an ultrasound of the patient with a previously infected child.
Right.
Or genetics, maternal fetal medicine.
Again, it comes back to informed consent. Pretty much all of these history of things come back to informed consent. You know, okay, you had this in the past, this is your chance of it recurring, what do you want to do about it? And how is it going to change the course of her care that I've referred her to an OB? It isn't going to change the course of her care or make her safer. It shouldn't be on this list.
Well, I think adding the word significant between prior significant fetal structural chromosome abnormalities, and then I think adding the affecting mode of delivery, because if it affects the mode of delivery, then that would be a reason to have a consultation.
But why do you need an OB if it's not diagnosed?
Why does she need to see an obstetrician until that condition is confirmed in the current pregnancy?
Well, and that's the issue, is that how likely is it to occur, and right, this may be something on
the CNOP says that the licensed midwife doesn't have the ability to offer the test that the woman needs to determine if this similar problem or exists in this pregnancy. And that's not the case. So it shouldn't require an obstetrician until it's diagnosed. Until the baby is diagnosed with spina bifida.
There isn't going to be anything you can do to prevent a baby with spina bifida. Once it's there, it's there.
Yeah. And then we do on the is it B or 2? On the B, there is fetal abnormality suspected. So
right,
it's there.
Arising during the pregnancy.
I mean, I think one of the things that we're running into here is we're trying to sort of create like practice guidelines by just replacing, or inserting an OB consult into all of these issues where something else would be more appropriate. Like in this case, an ultrasound would be pretty appropriate and a bunch of other testing. But since statute doesn't direct us to create practice guidelines,
right,
it only is directing us to talk about these physician examinations, then it doesn't really fit. We're sort of wishing we could say, well, of course that's what you should do next. The statute doesn't say, should you do an ultrasound next?
I don't think it belongs on this list. So it's struck. 21 is history of preterm birth at less than 36 weeks.
I thought we had covered that with history of squash.
So that's another one, again, that in the previous IP meeting we came to some agreement with, and then the ACOG representatives on the phone had concerns about.
We know that preterm birth is something.
I was going to say, this gets back to the whole idea of whether an OB can predict something's going to happen. We talked about this at the very beginning with the VBAC issue, at the very beginning, that you can't predict a uterine rupture. And here, with preterm birth less than 36 weeks, again, it includes counseling, it includes taking a good history, doing appropriate testing if necessary based on what the history of their preterm delivery or the etiology of their preterm delivery was. But a consult at 15 weeks with an obstetrician isn't going to tell them anything that their midwife isn't able to counsel them to do. Midwives are trained to do this sorts of things. So it's, again, it gets back to the same thing. You know, I made notes the same thing, we're not there yet, but to IUGR and severe preeclampsia at the beginning of this pregnancy, too, it's the same thing. What does a physician exam earlier in the pregnancy do to, what's the predictive value of that test early in the pregnancy? And there isn't one until the problem is diagnosed. Unless you just assume midwives are incapable of counseling people properly, with this kind of the feeling that I'm getting that ACOG, not this panel, but ACOG, has that feeling, and is in the literature the way they've treated midwives in the past several years about home birth and all the stuff that's come out. So I think that a lot of this is coming from ACOG's idea that for some reason midwives are incapable of counseling people, which we make very clear today is not true, because there's no predictive value in seeing somebody with a physician. I think I've been redundant now. So you get my point?
My understanding, I'm new to the process, but before, I think my understanding the goal of all this list was to try and define abnormal as opposed to normal. The idea was to try and somehow define abnormal, and it's just to go through every issue and try and...
Why you think that? Because B says, as used in this article, the practice of midwifery constitutes the furthering or undertaking by any licensed midwife to assist a woman in childbirth as long as progress meets criteria accepted as normal. And then there's lines, and then it says, I'll just continue on. Except as provided in paragraph 2, a licensed midwife shall only assist a woman in normal pregnancy and childbirth, which is defined as meeting all the following conditions. There is an absence of both of the following: any pre-existing maternal disease or condition likely to affect the pregnancy. And that's what we're working on right now, are those things that require a physician consult, because they're likely to affect the pregnancy.
The whole process is to define or abnormal, I guess, or what's not normal.
So I would argue that a history of preterm birth is likely to affect this pregnancy because we would give her medication early in pregnancy, intramuscular progesterone, to prevent and reduce the risk of recurrent preterm birth. And that is within standard of care.
For every time you have a woman show up who's had a history
of preterm birth at less than 36 weeks. And there are some, if she had a iatrogenic or a indicated preterm birth, like she had severe preeclampsia at 34 weeks, then it's not an indicated. But if she came in with preterm labor at 35 weeks, then she is a candidate for intramuscular progesterone starting at 16 weeks. So it does affect her current pregnancy.
How likely?
More likely than... It's not likely that she'd go into recurrent preterm birth, but it is likely that she would be a candidate for progesterone treatment.
If it's not likely that she'd go into preterm birth, why is she a good candidate for progesterone?
Because the studies have shown that progesterone reduces the risk of recurrent preterm birth by 30%.
So the studies have shown that midwifery care reduces the likelihood of preterm birth quite a bit also. We have taken care in our practice of a number of women who come to us with a history of preterm birth, and none of the ones with a history of preterm birth have given birth preterm a second time. Of course, there are always the ones who have never had a preterm birth before who have had preterm birth, but still significantly less than the number in the general population. I would venture to say 2% at most.
The statistics for preterm birth for midwife-attended deliveries is 1% right now.
I think we have to be careful of selection bias in that situation as well.
Well, that just doing a good job.
That just proves it.
Well,
So they're doing a good job of selecting our clients.
Regardless of selection bias, if it's the same clients who are going to select us for their subsequent pregnancy, and they're, have done a certain amount of research, they eat well, whatever you want to attribute to this population as a stereotype, it's still the same population. So if the selection bias gives us a 1% prematurity rate, it gives us a 1% prematurity rate. I think the other thing to look at with this is the progesterone treatment, first of all, is kind of new, and the standard of care may evolve. And of course, that's the case with any of these things. But if the progesterone is the only thing, then maybe we, at the very least, if not removing this one, then we at least only require this physician examination for the women who would really be candidates for that. So, not people you were just listing, not someone with a history of multiples or inductions previously or whatever other reasons, those people who would not be candidates for the progesterone later, if we don't just remove it entirely.
Can I just ask a question? We have noticed that people come to us from all over the country, all over the state, and standard of care may be true in a large population center like Sacramento or San Francisco or LA, but it's not standard of care in many other parts of the country. We watched people be diagnosed with gestational diabetes in one part of the state, and people in the other part of the state had the exact same numbers and were not diagnosed with gestational diabetes. So we know that standard of care is a constantly evolving and geographically dependent sort of thing, and the same thing that happens in the wilds of North Dakota is not the same thing that happens in downtown Sacramento. So we have to look at this with a grain of salt also.
Just to quickly respond to that, I mean, medical legally, there is only one standard of care. There's not a standard of care in the Central Valley and another one in San Francisco. And so, I mean, as much as you like to define it, I mean, the standard of care, unfortunately, is what the expert witnesses define the standard of care to be, so you're always at mercy. But ACOG clearly recognizes that there is a single standard of care, and there can be local variations based on the resources, but there is only a single standard of care, and it doesn't change depending on the location.
I'm going to propose that we come back to this one because we've been making such good progress. I want to see if we can get through some others. 22, history of intrauterine growth restriction.
I think this should be removed from this section. It should be included in the second section.
Evidence it's a current issue.
It's there under 18.
Right. I don't think it needs to be in this section. There's a history of growth restriction. It's not affecting, it's not present in the current pregnancy. It doesn't need to be in this section.